Good afternoon.
Hey everyone, my name is Bradley Fox. I'm a second year radiology resident at Jackson Memorial in Miami. Thank you for joining for tonight's webinar on renal ablations. For everyone that's listening, if you have to step out, this is being recorded and it will be posted on YouTube for you to watch at a later date. If you have any questions, you can type them in and we'll try to go over them at the end. And so without further ado, allow me to introduce our presenter for the evening, Dr. Constantino Pena. Dr. Pena is an interventional radiologist at Miami Cardiac and Vascular Institute, where he is the medical director of vascular imaging. He's also a clinical assistant professor of radiology at Florida International University College of Medicine and an affiliate assistant professor of radiology at the University of South Florida College of Medicine. Dr. Pena, thank you for speaking tonight.
Thanks, Bradley. I hope everyone can hear me. I'm going to go ahead and get rid of my camera here and get going. All right, can you guys still see me, or is the webcam gone?
We can still see you.
All right, so what we're going to do is we're going to talk a little bit about percutaneous renal ablation. And we got a lot of material. I'm going to try to cover as much as I can here. So you guys can see my slides? So
Yes.
These are my disclosures, really nothing pertinent to what we're going to talk about today. So the objective of today's webinar is really to understand the basics of renal mass classification and therapy, recognize the differences between radical nephrectomy, partial nephrectomy, ablative therapies, and surveillance. And then we'll discuss ideal indications and selection criteria for percutaneous ablative therapy. So the outline, like to discuss epidemiology of renal cell carcinoma. Then we'll discuss about treatment options, particularly for T1A tumors, and we'll talk a little bit about what that means. And then a little bit about T1B tumors and lesions. We'll review radiofrequency ablation, cryoablation, as well as IRE and microwave. We'll then have talk a little bit about techniques and how to avoid complications in terms of these therapies. When we look at data in terms of the incidence of renal cell carcinoma, we have approximately 60,000 cases diagnosed a year, with approximately 15,000 cancer deaths related to renal cell carcinoma, and that's been relatively stable, probably for the last 2 decades. When you look at renal tumors, it's interesting to note that about 80% of them will be malignant, 20% of them are benign, and it's really, we're really unable to differentiate benignity or that something is benign or malignant with imaging. We do know that larger tumors have a greater chance of being malignant, and we know that localized tumors can be less aggressive, but once they become advanced and they grow to bigger sizes, they become very aggressive and have very poor prognosis. At presentation, I would say about probably something about 2/3 of these tumors present at a localized stage, with about 10% to 15% becoming presentation when they're very locally aggressive, and metastatic, and probably about 1 out of 5, or maybe even less than that, with a survival of less than 2 years. When we look at staging, really want to use the TNM staging. And really, when you look at tumor, the most important part here is it limited to the kidney? And what's the size of the tumor? So when we look at stage tumor 1, we're looking at tumors less than 7 centimeters. And we divide that into A and B. Less than 4 centimeters is T1A, and between 4 and 7 centimeters is T1B. When you start having the tumors that extend beyond the kidney and Gerota's fascia, then you start getting into T3 tumors. And again, these are divided as to if it involves a renal vein, if it involves the cava, or extends to the adrenal gland or beyond Gerota's fascia. When we look at lymphadenopathy, really a binary, if we have one regional lymph node or more than one, N1 and N2, and distant metastases. And this is important because as we start looking at TNM survival, you can start seeing that if you have a T1 lesion, a 5-year survival is quite high. once you start getting to larger lesions, the survival drops. And as you could expect, if you start having adrenal involvement, if you start having venous involvement and lymph nodes and systemic metastases, then the survival also drops. So we look at T1A lesions. These are localized lesions to the kidney. These are less than 4 centimeters, and they comprise 70% of all renal masses. These are asymptomatic with a very small indolent growth rate of probably estimated about 3 millimeters per year. The risk of, and this is an important point, talks about risk of metastasis of presentation is actually quite low. And, numbers talks about 5%. It's probably lower than that, particularly in these small lesions. However, once the lesions start getting bigger, that increases the risk of metastasis significantly. So I think when you're looking at a 3.5, 4 centimeter lesion, it's much different than a 2 centimeter lesion or a 1 centimeter lesion. We talk about the subtypes of renal cell carcinoma. I think the most common subtype is clear cell carcinoma, and they can have different grades, and that's about 80% of renal cell carcinomas. When we see a papillary carcinoma, these could be basophilic or eosinophilic, which are a little bit more aggressive. And when I see papillary, I was worried about multiple tumors. Chromophore, again, these are going to be 4% collecting duct carcinoma, even rare, but much more aggressive. We look at risk prediction. Again, as you get a smaller tumor stage, you're going to have less risk in terms of metastasis and metastasis-free survival. So if you're able to get less than 2 of these score points, so again, T1A or T1B, I think you can pretty much say metastasis for survival should be quite high if you can treat someone this localized. One note about hereditary renal cell syndromes, I think the most common was von Hippel-Lindau, but these are patients that can present with multiple renal masses. And I think this is important because as we start seeing the development of ablative therapies, it was really these patients that we were trying to treat and protect renal function in patients that could have multiple RCCs and try to treat them and prevent renal function. So this is really where, in this population, where we really got a lot of our experience in treatment of these small renal cell carcinomas. So what's the present management algorithm? I think it's important to understand really what you're looking for is surgical resection, radical versus partial nephrectomy, or what we call nephron sparing surgery, ablative therapy, and active surveillance. The latest guidelines were produced and published last year from the AUA, American Urological Association, and these really started looking at the different management criteria. And I think to me, there was a shift when you looked at these management guidelines to the previous management guidelines in 2009. And that now we see that thermoablative therapies are considered an alternative to surgical therapies. Partial nephrectomy really should be the first line of what we can try to do. And really, we go to radical nephrectomy if we really think it's necessary in a certain patient population. And then active surveillance is now being better defined. Exactly how active should you surveil a patient? What are the criteria about surveilling a patient? And we'll get in a little bit more detail with these. But as you can see here, this is kind of that algorithm. So partial nephrectomy or nephron sparing approaches, really, I think this should be prioritized in these patients, particularly in patients with not ideal renal function. Radical nephrectomy, again, in situations where there's increased oncologic potential, I would think it's important. And then thermal ablation, consider an alternative, particularly for lesions less than 3 centimeters. And I think this is important. And this 3 centimeter rule, if you remember one thing today, is going to be about that 3 centimeter rule. The second thing I think is important is that renal mass biopsies should be performed, particularly in patients prior to thermal ablation. And then when you speak to patients about thermal ablation, be sure to discuss the fact that you may have a recurrence that may require secondary treatments, which I think are a lot less morbid with thermal ablation than other therapies. CIRC guidelines also came out in 2017. And again, what are the indications for ablation? So comorbidities that have an increased risk for surgical intervention, patients that you need to protect renal function. So impaired renal function, single functioning kidney, more than one small renal tumor, and patients that do not want to undergo a surgical procedure. So standard indications, very similar to what we just talked about. So what about image-guided therapies, and what are we talking about? And I think it's important to understand as we start doing ablative therapies for these renal lesions, is that the advantage is that they're quite straightforward procedures. They should have a quick recovery, that they should be nephron sparing and really focused and precise to what we're treating in the kidney. Some of the disadvantages, however, are that we're not having enough biopsies, and I think it's important that we can't really follow these patients. Do you have cancer? Do you not have cancer? Did you have a mass? What's the malignant potential of that mass? Unless we perform biopsies so we can follow, and the patient can get better surveillance and follow up afterwards. There's a lot of different options. So radiofrequency ablation was what we first started using for these kind of therapies. Now much more mature with cryoablation, microwave, and IRE. So the objective of percutaneous therapy is really to control oncologic control and preserve renal function. Here's an example of a patient with a single solitary kidney. You can see that there's a lesion here in the right kidney. Patient is now prone, and you can see an electrode being placed, a probe being placed, and patient is being treated. So again, what's the ideal ablation? And we used to talk about A, B, C in terms of exophytic being A, B being kind of in the middle, and C being more of a central lesion. I think this is important when we look toward the ideal ablation therapy. But I think it's important to understand when you perform ablation, whether you're giving heat or you're creating a cryoablation or freezing a lesion, you really have to understand how much energy is being deposited, how long you're depositing it for, and really what's going to cause that amount of energy to cause cell death, and really how predictable that cell death is, and can you predict the margins that you're going to get? So predictors, what's important, I think, again, really important thing here is the size of the tumor. And I think that's really the most important part. If you have a tumor that's 3 centimeters or less, your therapy should be equivalent to surgical therapy. And that's really what the studies have shown. And I think that's important. And then you're going to say, where's that tumor located? And can I approach it and get my needles or my electrodes or my probes or my antenna in a proper location that I can get that type of outcome? And that's really where your assessment of the patient and your assessment of the lesion. So again, as you see, the 3 centimeter rule is that if you're able to get a lesion that's less than 3 centimeters, you're pretty much technical success of these tumors, particularly they're exophytic, is almost 100%, 97 to 100%. Once you start getting greater than 3 centimeters, this does drop down in the 90% range. So if you're going to remember one again, 3 centimeters or less. This is a very interesting algorithm published in 2014 by Dr. Atwell, and really talked about when you're looking to plan an ablative therapy, look at the diameter, which is size, and then look at the location within the kidney. Is it adjacent to the ureter? Is it touching the renal sinus fat or more central? Is it more endophytic than exophytic? And these are things that are important as you start planning this therapy, as to give you an idea, do you need to do any additional adjunct manipulations to decrease complications and get better outcomes? And is it really the best lesion to be working on? And what are you going to do to make sure you have a good margin and good result? So watch out for medial inferior lesions. I think this is a really important take-home point. As you can see, the ureter runs really close to these lesions, and I think it's important. That's going to help you plan these lesions. So that all really goes into planning and trying to select the best treatment. Again, a follow-up of these lesions, I think it's important that there's a team approach. I think I work very closely with my urologist to follow these areas and really have a team approach as to which patients we should treat, which patients we should surveil, how closely we're going to surveil them, communicating back and forth as to what we see on the follow-up scans. I think following up a scan in 6 months is pretty much what I do, unless there's something really particular about that lesion or the patient has a really increased concern. I think you're not going to see much of a growth rate. If you're looking at these lesions should grow 3 millimeters a year, I think you're not going to see much difference if you're going to go much closer than that's in that kind of time frame. So how does ablation work, and what are the different mechanisms, and how are they different? Radiofrequency ablation, and the way I describe radiofrequency ablation is we place a probe. That probe can then have some tines that increase and give us more surface area. But really what we're doing is using the AC current to create vibration. That vibration agitates the ions, and it's that kind of agitation that creates friction. And that frictional heat is what creates heat, which is conducted into the cells and into the tissues that needle is in, and it creates that necrosis. So really, when you look at that type of radiofrequency system, what you're looking for is that trying to create energy to create heat, and that heat to give you some type of cell death. And how do you measure that cell death? A lot of times we like to look at temperature, because we know that if you read a certain temperature for a certain amount of time, you should be able to get cell death. How do you measure the temperature around the probe or the tissues so that you know what your margins are is, I think, somewhat debatable. Some people will place thermocouplers. I usually did not do that, but something that you can do to measure what that temperature is, maybe surrounding the area that you're trying to treat. And again, you can see here this kind of picture of what you're looking at, insertion of the needles, opening the times, creating your radiofrequency ablation. And again, what you want to do is get to that 100 degrees Celsius and be able to hold it for at least 5 minutes to try to get cell death in that area. And there are multiple different types of probes and how they may work. Again, different systems have different endpoints, whether it's temperature, whether it's impedance, whether it's time. And really, I think a classic study really came out of Mass General. They looked at 10-year data of using radiofrequency ablation in T1A and T1B lesions, and a follow-up here greater than 6.5 years. And what was interesting in that in this study, and published in 2013 now, so almost 5 years ago, they saw that residual disease was low in the T1A lesions, local recurrence, again, low in the T1A lesions, and disease-free, 5-year disease-free survival, 92%. Again, expected to be higher, but I think for initial work, 10-year data, this is quite good. And it really validated the importance of this technology and the importance of having good data, really biopsying these lesions, be able to follow these patients and treating these best lesions, particularly when you look at size of the lesions. Again, this is that same article looking at that in terms of T1A lesions and T1B lesions, that there's definitely a difference when you treat smaller lesions as opposed to those greater than 3 centimeters. Another important abstract, which I thought was important in RSNA 2003, looking at smaller lesions. Here's 100 renal cell carcinomas, 5-year follow-up with radiofrequency ablation. Again, you're looking at primary technical success of 86%. Sometimes you may have to do a secondary treatment, increases that to 95%. But again, very low local progression. But here we really talked about what defines a great result and what are the factors that predict a good result. And I think here, again, things we've already talked about: the size of the renal mass, the location in the kidney, the number of ablation zones you're going to do, and again, staying away if you can from the collecting system and surrounding tissues. So in conclusion, radiofrequency ablation, something we did very early on, probably do it very limited now in today's practice. But I think it's basically laid the groundwork for all the different ablative therapies we have today. And really what we know now, it has similar long-term outcomes as partial nephrectomy for tumors under 3 centimeters. It's a low impact procedure with less morbidity. The size and location is really important for the predictors of success, and it's minimally invasive. Changing gears a little bit, about the next kid on the block was really cryoablation. And cryoablation is an interesting story, as it really started in the operating room. I think when we first had our first treatments with cryoablation, a lot of times it went in the operating room. And the initial studies that you'll see are really in the operating room, placing a lot of these needles in the operating room. And I think that's why initially some of the results were much better for cryoablation. I think we're looking at 2 different sets of studies in those days: percutaneous kind of radiofrequency and more intraoperative cryoablation treatments. But the way cryoablation works basically is based on the Joule-Thomson effect, that as you freeze and thaw gases, they expand and compress. And when they expand and compress, you have a huge change in temperature. So when you really have expansion and change in temperature, you start creating this as they compress these gases, they really create a huge cooling effect, and they can create that ice ball. What we see really is using the traditional gases or argon that cools during expansion, then helium, which we use to warm or thaw and create that thawing effect. So really what we would like to do as we do this type of freeze and thaw cycle is to get at least 5 millimeters beyond the tumor with the ice ball. I think it's important to understand, I don't think we really know where the lethal ice is and where the non-lethal ice is. So we really want to get as much control on the margins as we can. We know that if you can get down and freeze and thaw, not only can the temperature cause damage, but also that rapid freeze with the thaw can cause those cells to rupture, and then creating really that type of intracellular death by free water diffusion. So cryoablation, again, placing the needles, being able to then create that ice ball. A lot of times you'll create an array of several of them to create a larger ice ball. And really what we're trying to do is get down to that -20 to -35 degrees to create that amount of ice. And it's not just creating the ice, but it's the thaw and then creating the ice again. A lot of times what we traditionally use is a freeze, thaw algorithm. And I think the biggest advantage of cryoablation is that we can see the ice ball. And when you can see that ice ball, you really, I think, have a little bit better demarcation of what you're treating. And you can then help you determine if you need to treat or place other treatments at the time of your initial treatment, making secondary treatments with cryoablation, I think, much less than in the radiofrequency or in the microwave treatments. Cryoshock is an important side effect, and that is that you can, as you thaw, you can have intracellular contents that may diffuse out. You can get patients that can get some kind of rapid release, and they a lot of times it's marked with some hypotension, and these changes, which I give a lot of fluids for, really haven't had a significant cryoshock case. But here's an example. Here's a patient, 67-year-old patient. You can see a 2.6 centimeter mass in the upper pole of the right kidney. See that mark there? Being able to then place 2 probes, in this case 17 gauge probes, and then in follow-up you can see what it looks like. You start seeing what we call the pseudoangiomyolipoma look to it. You can see in a lot of these lesions where you see that fat necrosis creating a ring around the area that's treated. And you can see a typical where now there's lack of enhancement. In this particular study that looked at a review of cryoablation published in January of 2016, I thought this was an interesting study, and basically looked at all that was published and included about 82 studies, basically showed that there's slightly higher local recurrence compared to partial nephrectomy, but that cryoablation is a good alternative to partial nephrectomy in patients that are not good surgical candidates. That again, the same theme that we need to do more biopsies. And again, the cryoablation is nephron sparing and can protect us in terms of protecting renal function. In terms of microwave ablation, how does this work? Microwave ablation really works with antenna. We place these antenna, which will create electromagnetic microwaves, and they will then allow these microwaves to go from one antenna to the other, or if they're sometimes in the very same antenna, we'll be able to basically allow for energy absorption through the microwaves, and then allowing the energy and the different ions to go and to create this type of heat. What's important about microwave when you compare it to, let's say, radiofrequency ablation, is that you start seeing that even though it's frictional heat, there's a lot less importance with surrounding structures. I think you're able to get a lot more heat, and that you're able to get a lot higher intratumoral temperatures. So what we'll see is faster ablations, excuse me, with larger tumor volumes, ablation volumes. In this particular study, looking at midterm results, they compared laparoscopic versus percutaneous ultrasound treatments over a 6-year period. This is an interesting study as they looked at a large number of patients. Most of them were laparoscopic, but you can laparoscopic nephrectomies, and you can see here that with tumors less than 4 centimeters, survival at 5 years was 82% with microwave compared to 86%. But that the survival between both of the, in terms of cancer survival, was very similar with both groups, and the complications were very comparable. A lot of times you select patients in some of these studies for microwave, and that's why they got treated that way. Irreversible electroporation, IRE. I think my partner Raj Narayan does a lot of work in this area in terms of IRE. And initial studies, really what we see is 33 patients in 2016 were reported, phase 1 and phase 2 trials. Again, with IRE, you're using these very small electrodes, or very small electrodes, and able to create an array with them. And once you're able to create an array, you're then able to create a very systemic form of ablative therapy back and forth, and create a whole area of ablation in a very subtle manner. I think what we like about IRE is that really it keeps the collagenous skeleton in the tissues intact. We see that, however, it does cause that type of cell death, but keeps the exoskeleton intact. So again, this has been helpful in certain structures. I think we're still studying in the kidney, and initial work was written by Clayton Trimmer in 2015. And he looked at 20 patients, 13 of them with T1A lesions, and showed good results. And here's an example of one of these cases. Place 4 probes. Again, you want to place these arrays in parallel form, and the treatment there. And you can see there after the treatment. 1 month follow-up, you can see that post-ablative area with IRE. Now what I wanted to do is speak a little bit about complications and follow-up of these patients. I think when you look at follow-up, what's the ideal follow-up? How do you want to follow patients after you treat them? I think obviously you want to have a relationship with the patient, be part of that team before the treatment. And then you want to set up your follow-up interval. Routinely, we follow these patients up at 3 months. I think there's too many changes going on the first 3 months after percutaneous ablation, whether it's radiofrequency, cryo, microwave, or IRE. So we may see them in the office in 1 month, but a lot of times we won't do imaging until about 3 months. If that imaging at 3 months looks good, that there's no residual tumor enhancement, we will then extend that to 12 months, and then start with 12 months, then yearly follow-ups after that. If there's any evidence of recurrence, whether it's in the tumor bed or adjacent, then at that time, we'll go ahead and schedule for a follow-up treatment. What about T1B lesions? So now lesions 4 to 7 centimeters. I think this is important because as you start getting bigger, you start seeing that your results start going down. So 3 to 5 centimeters, you're looking at 92%. Greater than 5 centimeters, your results in terms of your treatment is only 25%. But also what's important is, as these tumors get larger, I think you have a lot more complications, whether it's bleeding, whether it's nearby structures, whether it's post-operative neuralgia, because you have the nerves that are surrounding that area, particularly surrounding the kidney, and the radicular type pain. So I think this is really important when you start looking at larger lesions. Again, the team at Mayo really has published a lot on these larger lesions. And I think cryoablation of large lesions greater than 7 centimeters is technically can be done, but I think there's a lot more complications. I think that's what they wrote in this series of 12 patients. I think there's a more recent paper that they published recently. Again, they start looking at these lesions 4 to 7 centimeters. And in these particular cases, they recommend some hydrodissection. Sometimes you have to do renal collecting system protection, again, just because of the size of these lesions. They did publish about using intraarterial embolization when you treat some of these large tumors, and this is something that we started doing in lesions that are greater than 4.5 centimeters. Again, trying to do some kind of bland embolization followed by ablation, usually the next day. So here's a 65-year-old patient with history of lymphoma and a renal mass. You can see that mass, solid appearing mass. Patient obviously had a biopsy that was consistent with clear cell renal cell, and we treated that patient with cryoablation using 5 probes with those type of results. Here's a 65-year-old male with renal insufficiency, presented with a right upper pole renal mass initially, and you can see here that mass was small. This patient had papillary cell cancer, and you can see that we're trying to treat this lesion here. You see multiple small solid lesions. At the lower pole, we thought this looked like a cyst. Patient was biopsied again and treated for papillary. So again, you're going to follow this patient very closely. You can see here using MR. And again, you can see 1-year follow-up, a good result, no enhancement. But you can start seeing that this cystic area, the lower pole, started getting bigger and bigger. Got up to about 5 centimeters, said maybe we should biopsy this. Came back again, consistent with papillary renal cell, at which point we performed an embolization with 100 to 300 micron particles, and then performed a cryoablation with 6 cryo probes. You can see here the size of that ice ball. And then 3-month follow-up, 9-month follow-up. We now have 2-year follow-up on this patient. Is still doing well. Again, it's hard to follow these patients up when they're cystic because you're no longer looking at enhancement. So here you're looking for changes in size. I wonder if there's another way to follow these, maybe even diffusion with MR. So I think there's still some work to be done there. So when you're looking at heat-based treatments in renal cell carcinoma, I think the collecting system is something that's important. Sometimes you don't want to treat 2 central lesions. Sometimes you have to. I think it's important to understand whether you're going to place a ureteral stent and try to create flow and to protect the collecting system. I think it's at risk, particularly the lower pole, that you can cause stricturing. It can lead to a loss of kidney if you don't pick it up, if you don't pick up early enough. And these are patients that, again, I may image earlier than 3 months if I think there's any risk of the collecting system. Here you can see a patient, you don't really see the ureter being able to position and trying to treat that lesion, but you can see that now the patient had a dilated ureter. When you do something in the medial aspect here, we like to go for cryo, where you can really kind of see the outline of the ice ball and really see the ureter the best you can. When it touches the collecting system, again, maybe microwave is better in this type of positioning. Maybe IRE will be better in those positions. I think we still need to know, in a more central lesion, do you want to use an antenna with microwave to help protect the collecting system? And I think those are things that we're trying to figure out, which situations are tools best used to kind of diminish our risk of a complication. So again, here's that central lesion, and afterwards it's therapy. So again, you want to really match the lesion, the size of the lesion, the location, with the therapy that you're doing and you're using to try to get the best results and try to minimize your complication. At the same time, you also want to make sure you have good tumor geometry, that you're covering the entire tumor, that you're getting a margin. And sometimes it's difficult to really ascertain what's a predictable margin. When you place a 3-centimeter probe, are you always going to get a 3-centimeter burn? And how is that burn going to look? I think we don't know. And the cryoablation, I think, helps us with the ice ball, but we know that that's not always 100% in terms of what we're seeing as ice, in terms of lethal ice. So when you perform ablations, I think it's important to understand that you may get where what you think you're seeing and your ablation and your tumor geometry match, you're going to get a successful treatment. But sometimes that tumor geometry is bigger. You're going to have recurrence. You're going to have you're going to miss part of it that requires you to go back and treat it again. Or sometimes the amount you treat is much more than what you wanted. You're going to get collateral damage and loss of kidney function. And again, if they're not overlapping, you may miss it completely, and you may end up with losing some nephrons and not having treated the tumor. So I think that's important as you start planning these areas. So again, a graphic looking at how we define success and what we can see after these therapies. So again, suboptimal ablation may be related to heat deposition. Again, in radiofrequency ablation, we may get charring and not enough heat. If you don't get enough heat, you don't raise the temperature and keep it there for a significant amount of time so you can get that cell death. You may have a heat sink effect. Again, the geometry is also important. So again, looking at geometry, looking at heat sink, if you're close to an artery radiofrequency, you may not get that long-standing heat that you need. So again, risk factors for recurrence, at least with radiofrequency, we talked about patients that have history of renal cell carcinoma with multiple bilateral RCCs. It's important. You're going to be able to have to treat those patients over and over again. How do you define a recurrence and the importance of imaging? This is probably the best we have right now in terms of imaging. You can see here that there's a residual area just medial to this, what we see, that pseudo AML sign after we've treated something with fat necrosis surrounding that ring around that treatment lesion. You can see at the margin that that area is growing, and then you have a retreatment. So again, how do you mitigate these complications? You want to really focus on good margins. If you need to place an extra probe or an extra needle, place it at that time. Pyeloperfusion to protect the collecting system. If you're really close to the collecting system, may be helpful. Hydrodissection to protect colon or bowel to, again, allow you to get the best margins you can. And then again, using temperature monitoring, thermocouples if you need to, particularly if you're treating somewhere close to the spine and very large lesions. Always look about what's the most vital structure that I'm near. What's the most vital structure and what do I need to protect it? In this case, bowel, placing a needle, giving some fluid to separate that bowel and creating a safety barrier with that fluid. So I like to finish off with this study. This is a recently published study. I think this study and the editorial written by Michael Sulin really are two really important documents. There was a recent paper published in the Annals of Internal Medicine looking at the role of thermal ablation. But I thought this is definitely a much more complete paper, looked over 10,000 patients in this database of surveillance, epidemiology, and results, really Medicare-linked population study. So these are all older patients. And I thought what they found was the cancer-specific survival differed between partial nephrectomy and radical nephrectomy. Also differed between surveillance and ablation, and surveillance and partial nephrectomy. So I think it's important if you're looking at surveillance, you really have to have an accurate surveillance plan in place. And that if you see some kind of change in size, when you're going to pull the trigger and what you're going to go ahead and treat that patient. But they also found that there's no significant difference between thermal ablation compared to partial nephrectomy and radical nephrectomy. And when you look at 9-year cancer-specific survival rates, they're pretty much comparable between partial nephrectomy and tumor ablation. And I think when they saw that, with the exception of cancer-specific survival in active surveillance versus radical nephrectomy group, cancer-specific survival and overall survival for all of the active surveillance comparisons was lower. So I think we can use surveillance, but I think surveillance may have a role, particularly in very older patients or with limited lifespan patients. I think that's really important. I think in addition, it was also very important what they found was that compared to patients undergoing ablation, those that underwent partial nephrectomy or radical nephrectomy had increased risk of renal, cardiovascular, and thromboembolic adverse events up to 1 year after the procedure. So again, selecting the patient I think is important, and I think this is why I feel that there is a role for tumor ablation in our treatment of our patients. And they concluded that for T1 lesions, so we know small lesions, 3 centimeters or less, that tumor ablation confers cancer-specific survival and overall survival similar to surgery. And I think if there's one thing you're going to remember about this talk is that. So in summary, I'd like to say ablation is a viable option for T1 lesions, particularly those less than 3 centimeters. I think RFA and cryoablation have similar long-term results, even though the studies are probably done very differently. Cryoablation may add a little bit more precision because of this visible ice ball, but don't necessarily count on the ice ball every time. There may be non-lethal ice. We really don't know where we can draw the line of where the margins are going to be. I think there is a role for non-operative T1B renal cell carcinoma in patients that can't get surgery, again, combination of embolization and ablation. And then there's been an evolution between RFA, cryo, and now microwave in terms of what's the best thermal treatment to treat these lesions. And, with the latest guidelines, ablation is considered an alternative to partial nephrectomy. And I think that's important. And the role of surveillance has been better defined. And even though surveillance is sometimes something that we advocate, I think we really have to have and speak with the patients and let them know what you're looking at, what increased size in the lesion is acceptable, and at what level are you going to say, okay, we need to treat you, and really define those at the time of active surveillance, and really a team type approach. So with that, I'd like to thank everybody for their attention. I don't know if there's any questions.
All right, thank you, Dr. Pena. So for everyone that's listening, there's a a tab on the GoToWebinar for questions. You can type in your questions if you have any. I'll give you guys a few minutes here. In the meantime, Dr. Pena, I was wondering, do you perform your let's say that a patient has a CT for suspected, let's say, renal stones, and incidentally there's a renal mass there, and do you perform your biopsy on the same day as ablation, or do you do them separate?
I think that's a really good question. I think it go either way, and I think it really depends on the patient. So we may see a patient or a renal mass that I think is pretty clear cut that it's going to be what I consider a lesion that I'm going to treat. I may perform the biopsy at the time of therapy. And I think in those situations, what I wanted to do is minimize the chance of bleeding. So in those particular patients, I may place my needles first, my electrodes or my treatment needles first, then perform the biopsy. A lot of times I may use the biopsy needle to help me kind of isolate and get into the lesion, and then use it as a marker to place my electrodes and try to get the best placement as possible, and then perform my biopsies. But then there are other cases where when I talk to the patient, they're not sure what they want to do, or in the situations where we think the pathology may change how we're going to treat the patient. In those patients, I will do a biopsy first, and then wait at least 4 to 6 weeks usually before going ahead and treating them. And then if there's something that's not right, sometimes you see, after you see a lot of these scans, you start seeing and you say, what, I don't know about this lesion. There's something about it that's not characteristic. Then I'll perform the biopsy beforehand in those patients, and then treating at the same time.
Thank you. All right, so I don't really see anyone ask any questions. So thank you very much, Dr. Pena. This was a great talk, and I think we all learned a lot. Thank you.
All right, thank you.
All right, so that concludes our webinar. Thank you guys very much. This will be posted on YouTube.